So the practice patterns differ at various levels, depending on whether you're a primary care provider. Somebody comes to a practicing family physician and complains of a little redness or itching in the eye, and how he would treat this. If you're a comprehensive general ophthalmologist dealing mainly with cataract surgery, and a patient comes to you complaining of itching or redness or dryness sensation in the eye, and how you would treat this. If you're somebody like me in private practice and doing mainly cornea work, and a patient comes to me, and how differently would I manage this, and how they are managed in tertiary eye care institutes. So the practice does tend to differ depending on these. So if it's a primary care provider, he would guide the patients, ideally speaking, treat them for some time. If they don't improve, they should go to the secondary and then to the tertiary center, which would be the ideal setup. Unfortunately, it doesn't happen like that in our country, because sometimes the primary care providers are not even the family physicians, but they are our chemists and druggists. In our country, we are more democratic than Japan and many other countries, in the sense that patients can walk into a drugstore and complain to the pharmacist who's over there, who then prescribes medicines for everything from baldness to ingrown toenails and everything in between. So sometimes they get treatment from there, and usually it is an antibiotic steroid combination which is given, which only fouls up the work when the patient comes to an eye surgeon for treatment. So for the comprehensive ophthalmologist, my suggestion is use your ears before you use your eyes, so that you never miss a dry eye patient. Be suspicious in simple cases. I would say the A, B, C, D, E, which I have devised for dry eye, where A is aging. We know that tears are 60% less at age 65 compared to, say, a young man of 18 years of age. These elderly patients come to you for cataract surgery. They come from the rural areas where pollution is less to a polluted city to you. And then you diagnose them as having cataract, and you're very careful, and you ask for blood sugars, and the blood sugar is 125, and you say, my God, you got diabetes, and put them on sulfonylureas or some anti-glycemic agents which cause dryness. And you're very careful, you take blood pressure, and you say it's 130/90, it's going into malignant hypertension, and you put the patient on calcium channel blockers, which again cause dry eye. And then you do a wonderful job, and the patient is 6/3 within 15 minutes of your phaco surgery. But then patient complains of little irritation, and you load the patient with 1-hourly steroid drops. You don't want infection, so you load him with half-hourly antibiotic drops. And all these drops with preservatives cause dryness. So A is for aging, B is for blinking. We have so many computer programmers in our country working 14 to 16 hours a day on their computers and laptops. We have little children who are now being given a new babysitter, which is the iPad or the mobile phone. So when the parents don't have time, they put the iPad on with cartoons and whatever, and they're glued to these things. So the blink action reduces. When the blink action reduces, the tears don't spread evenly. There are dry pockets created, and in the long run, these patients go into dry eye. Even excessive blinking, which is a habit sometimes in kids, again the tears don't spread evenly and can cause a dry eye. So it's something to be kept in mind. Contact lens wearers, as our society progresses, more and more people even in smaller towns are opting to wear contact lenses. Not a bad thing at all, but overuse of contact lenses and misuse, not following instructions, can give rise to a disruption of the tear film. So you need to be to ask this history of whether they're wearing contact lenses. The drugs, the number of drugs which cause dry eye is increasing day by day. Even multivitamins now are supposed to have an effect, deleterious effect on the lacrimal glands, aside from all the other drugs that I told you about, antacids, anti-cold medicines, antidepressants, antipsychotics. In Mumbai, where I practice, almost 50% of my adult patients are on anti-anxiety pills or antihypertensives or antidiabetics because of the stress of city life. We need to know about this. We never stop those pills because our MD medicine people also have to survive. The pharma industry has to survive. But the point is we need to be aware so that we can add appropriate teardrops. And E is for the environment. It's not only pollution, but even air conditioning. My first patient when I came back from the US was a gentleman who was very moneyed. And I was very thrilled because I diagnosed dry eye in him, and he asked me, why are my eyes dry? And I said, sir, it is because of pollution in Mumbai. And he fired me because he says, I'm 24/7 in an air-conditioned environment. My car, my home, even my bathroom, my car, my office, my club where I go, I never step out onto the street. I am always in an air-conditioned environment. How dare you talk to me about pollution? So I realized the culprit was our air conditioning, which we need to know. In colder climates, it could be the heating, both of which could cause the room to become drier than what we like. So there are guidelines. The dues 1, dues 2 gave guidelines, but sometimes we feel when we are in private practice that this guideline-based approach may be too complicated for us to follow, because they tell you that you need to have a questionnaire and then looking at the symptoms, then go on to doing dry eye questionnaires, and then the staining and the breakup time in a particular order, and then decide the treatment according to this. Sometimes we may feel that these guidelines are a little complicated. Let me simplify a magnificent amount of work done in DUES 2, which was published in May of 2017, where 150 odd dry eye experts got together and came out with a 150-page literature on how to manage dry eye. We're not going to go through 150 pages, but what they say is, first thing is to ask what is called triaging questions. Some of them are, how severe is your eye discomfort? Do you get mouth dryness or swollen glands at the same time? You're trying to look for Sjogren's syndrome. How long have your symptoms lasted? Has there been a triggering event? Is the vision affected? Do you wear lenses? Do you have any other general health conditions for which you could be taking medicine? So suspicion is aroused if some of these questions are positive. These are called triaging questions. You have not yet diagnosed dry eye. You're just trying to see whether you should be suspicious. As I said, using your ears. If you suspect dry eye because of the answers that they've given you, then you do an analysis of the risk factors. Is he a smoker? Is he on certain medications? Is he on computers? Is he a contact lens wearer? So you ask further questions, and then you go in for diagnostic tests. In diagnostic tests, the screening tests which have been recommended by DUES are 2. One is called DEQ5, that is Dry Eye Questionnaire 5, which is, as the name suggests, 5 questions to be asked. It takes hardly 5 minutes to do. And the other one is the OSDI. So if the dry eye questionnaire, the smaller the number in you collate the answer. So for example, in the OSDI, there is question, how often do you need to put the drops? Occasionally, some of the time, very frequently, all the time. So all the time would be 4 points, like that. So the worse the dry eye, the higher the OSDI or the higher the DEQ number would be. And the DUES recommended that the DEQ5 number is more than 6 or the OSDI number is more than 13, then it is possible that it's a dry eye. So once you do that and you find that those numbers are elevated, then you can do the test that they recommend. And they say that if the symptoms are positive and if there is one of the 3 tests which is positive, then you've got a dry eye patient in your hand. The tests they recommend are the non-invasive breakup time, but if that is not possible, you can do the breakup time with fluorescein, which all of us have got. Osmolarity is difficult because only TIA labs makes these osmometers, which you can, they are expensive and they're not very reliable. Their sensitivity and specificity is not very good. And then you can do ocular surface staining with either fluorescein, rose bengal or lissamine green. If you're using rose bengal or lissamine green, it needs to be there for at least about a minute, minute and a half to actually stain the tissue. And according to the results that you get, you classify this into evaporative dry eye or an aqueous deficient dry eye. And then depending on what results you got, you see how severe it was. And depending on the severity, you will decide the treatment possible. Every time you look at a patient, you must look for meibomian gland disease, extremely common in our country. And the treatment of meibomian gland disease is a chapter by itself in this. So don't get confused by too many modalities. There are various ways, meniscometry, staining, and there are machines called ocular surface analyzers and LipiView, interferometry, all sorts of things are there. But the most followed algorithm, which I will show you, is a patient presenting with dry eyes, do a clinical assessment, not forgetting the eyelids. So history, taking visual acuity, Thank you. Comprehensive slit lamp exam, not forgetting the eyelids, and then you go for the diagnostics tests, which I mentioned about, and diagnosing this. Once you diagnose this, as I said, the Schirmer's test, wetting less than 10, non-invasive breakup time less than 10 seconds, and then the ocular surface staining. These are some of the newer tests which are there, which again I say that we don't have to do all this. With all this short introduction to the subject, it's my pleasure to introduce our speaker, Dr. Shizuka Ko. She's an endowed associate professor at the Department of Innovative Visual Sciences, educated at Osaka University, where she did a MD and a PhD and a fellowship at the University of Rochester in the USA, where I also incidentally trained. Her research interests are varied, but tear film dynamics, dry eye, wavefront sensing, optics, visual function related with the ocular surface, for which I heard her some time ago. It was fascinating. And even presbyopia and intraocular lenses. Without further ado, I invite Dr. Shizuka to give her presentation. Thank you so much.